The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only.
Hello, everybody. This is another episode of Life of Flow. Trying something else here today for y'all. We try to really be just as transparent and as organic as we are. This is really what we do on a regular basis. And earlier we were talking about what we should make this show about. And I was also discussing, hey, I've got this really complex case tomorrow. I actually need to tickle your ear. And then Lucas came up with the idea that why don't we just record our tickling? And that sounded weird. Record us going over cases because that's what we do.
This will live on the internet forever. I don't know if you know.
Anyway, stick around. We're going to go over this complex case that I have tomorrow. And then maybe if you guys listen to it, I'd love to hear what you guys have to say. Any experiences, any thoughts. You may agree, you may disagree, you may love us, you may hate us. That's fine. This is what we do.
Please shit post on Miguel.
Welcome.
On all social media platforms.
Welcome to the Unbiased. This is Life of Flow, the best vascular podcast. Stick around.
Vamos.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
Hello, everyone, and welcome to another episode of the Life of Flow podcast. And today we're improvising a little bit. We are going to do a little kind of pre-case discussion. Miguel has a difficult case. And this is something we sometimes do. We sometimes call our buddies and ask, hey, what would you do in one of these cases? It seems like there's a ton of landmines here. And that's kind of what we're going to do today.
Yeah. I think we do this not only on a regular basis, and it's something we've talked about before of how super important it is for you to always, ask somebody. And one of the things that I feel very proud of with some of the guys that I've helped train in the past is that we all keep in touch, and that we even have this chat where we throw some very complex cases, and it's a really interesting to hear everybody's opinion. And I'm sure, when we finish here, I'm actually going to go ahead and drop it in the chat and see what people think. But
we should have a series of the Unbiased, which is the name of the chat.
Yeah. I mean, honestly, we could just go back and randomly just flick the finger, and wherever it stops, that's what we're talking about.
Actually, that would be cool.
Yeah. And I guess the unbiased just comes from the fact that as vascular surgeons, but also very comfortable with endo, we would like to believe that we try to come up with the most unbiased approach to the way we care for patients. So I called Lucas today and I was like, I've got a doozy. I need your help. And we also needed to record. And so we just said, you know what, let's just record our conversation. So this has not been practiced before. This is just the way that we would go about this particular phone call. I guess we'll just potentially try to stretch it a little bit in the interest of trying to give you guys at least 45 minutes of something worth listening to. But anyway, I will preface by saying tomorrow I have a patient on the board, and this patient was a transfer from an outside hospital. And that call went a little bit like this. Hey, Dr. Montero, this is such and such. I went to a course that you did a year ago, and I have a patient that I don't feel comfortable taking care of, and I want to send them over to your facility. And I got a little bit of the blurb, but the highlights were very young, has a complex cardiac history, has been admitted with severe left leg pain that has been ongoing for months. It's getting worse, and it's at the point where he really can't tolerate it. And anyway, his brother is a CT surgeon.
Oh, wow.
And yeah, you're already like, God bless me. Thank you for this great consult.
Better you than me.
Yeah, and quite frankly, I'll be very honest. A lot of times when I get those calls, I don't ask a lot of questions. You know what I always say?
Send them.
I'll just, sure. That's it. Right?
Yeah.
Like, there's, the fact that this person went through the, through all the finding your phone, calling you, and very, in a very vulnerable and I believe quite professional way, saying, I don't feel like this patient, I can take care of them.
Yeah.
I'm reaching out for help. Golly gee, the last thing they need is for you to try to put them through a board's question. Like,
I
what?
know. Yeah.
And that's one thing that I've, remember I would always say that to you. I was like, dude, just say yes.
Just say yes.
What's the worst that could happen? You put the patient on an ambulance the next day after you see him. It's nothing. It's a nothing burger. But most times it's a none. It's something that needs to be done. And
yeah,
all you're doing is
that the person can't do it. It's just that where they're working, they just don't have the support to manage the patient.
And listen, this is my MO for anything. Consults, calls. Sometimes I will get a little bit more frustrated when it's like nursing calls in the middle of the night for stuff that I know may be punted. But even then, I try to be as courteous as possible because I don't think anybody does it out of malice. I think the sentiment that reigns is probably ignorance. And what do you get by just trying to beat somebody down and make them feel ashamed of their ignorance? How dumb! Like, what do you do to feel better about yourself and go home and be like, I really treated like shit that person? Like, right? Like, what? Come on, just say yes.
Yeah.
Help the guy figure out what needs to happen. Yeah, tell him, put him on a heparin drip, put him on a plane, put him on an ambulance. And then just kind of help the cause. Anyway.
Yeah.
So I say yes. I don't really investigate much. And then the guy hits the hospital. And then I go and I talk to the guy and I was like, oh, this is a bit of a grenade. This is way more than I thought it was going to be. So the gentleman's, he looks young outside, 59, has a complex cardiovascular history, active smoker. Let's start with that. So not because he would accept it, but because I could smell it on him. I mean, he's got that kind of yellow tarish pigmentation on his fingers and his mustache, and hyperlipidemia, hypertension, history of coronary arterial disease. Catch this. Guys had triple bypass in 2018, and including before the bypass and including after the bypass, the guy has had 17 coronary stents placed. In different parts of his heart, right? Every artery is probably full metal jacket.
How do you put 17?
I don't even know.
Where do they fit?
You can put stents and stents and stents and grafts and stents and things. I didn't quite count them. That is per his account, or maybe it's been 17 interventions. Anyway, then he has a history of a common femoral endarterectomy on the left. He also has a history of a femoral popliteal bypass on the left. That is the leg in discussion here.
Above or below the knee?
We'll take a look at the CTA. I don't remember. Maybe below. We'll look at it because, of course, it's graft. And then the left TMA is healed, but it's got, it's cold. He still has motor. Sensory is a little diminished, but he's intact. I mean, this is not acute limb ischemia. It's just profoundly ischemic. It's probably hanging by a thread. Can't get any Doppler signals. Then the right leg does have Doppler signals. It's pink. There's a little non-healing wound on the second toe, and that side has already gone through a femoral popliteal bypass too.
Both with vein, or
I believe both are graft. So anyway, cardiology is consulted. I want them to take a look. Obviously, do whatever you can. A PET scan comes back with some pretty reversible and moderate to high areas of ischemia. His ejection fraction and echo is 45%. Has changed throughout the years per the chart. It seems like sometimes it's been down in the 20s to 30s, but right now it seems like it's 45%. And so he gets caths, and his right RCA, his RCA is out. 2 of his bypasses are out. His Lima to LAD is open, but distal to the bypass, there's a significant lesion. And to get into every one of those areas, the cardiologist said I would have to mucker around all the old coronary stents that have been placed. And I don't feel strongly that this is something we could do. And here's the deal. As long as you don't need to do something too crazy. And so I was like, whoa, what does that even mean? It's like, well, and so then he said, Miguel, I know you. I'm sure you can figure out something minimally invasive if possible. This is just a guy you don't want to do a big aortic or a big procedure out of. I think he's just that guy. And if you feel very, very strongly that you need to do something more, then I may have to very strongly consider, putting on Impella and doing some sort of protected intervention, all for what seems to be asymptomatic, not necessarily because of, he doesn't really push the Mets right now. He doesn't really move because his leg's been the problem. And so when you ask him, well, do you get chest pain or shortness of breath when you walk? And the guy's like, well, I don't really walk much, and I've been stuck here for a while. This has been going
pain in his calf.
Because he's been having this rest pain that's been progressively getting worse. Yeah, he's got this kind of little dusky-ish kind of TMA, but like I said, still motor and sensory intact overall, to where it's just fairly ischemic extremity, but chronic in nature. So let's maybe take a look at the CT scan, and then let me know what you think, because it's not pretty.
Yeah, what's your goal with this? Just to get him to walk,
get him out of rest pain. I think that would be a massive win.
Yeah, but for how? Yeah. Oh, let's look at the CAT scan.
I don't know, Lucas. That's the reality. Is that with all these things, and if you add survival in the mix, I don't know what the long game is.
Well, the thing is,
because could you
his LAD mucked around with? I imagine soon. So once he starts walking, he's going to start getting chest pain. So what comes before the chicken or the egg?
That's a possibility. And then, to what extent, should I do something and tell him, if this doesn't work, you're going to get an AK. But at the same time, you'll see here, even an AK is at risk, I think, in this situation. So are you able to see that CTA?
Yeah, I got it.
I'm starting to go down. This aorta, which looks
pretty clean.
Inconspicuous thus far, right? Little CT, celiac trunk, SMA, a little bit of renal in there. You already, yeah.
Okay.
So one of the kidneys said bye-bye.
Oh, okay. Yeah, the kidney's not there.
Yeah.
Why?
You know what? That is a great question.
That is a good question.
That's a good question. Why does he not have I see surgical clips. So,
yeah.
could he have had maybe, and I'll absolutely pull the H&P here shortly, and maybe I can figure that out. That seems an important part of this, huh? All right, infrarenal calcification, and it goes down to the bifurcation of the iliacs. Lots of circumferential calcium, but nothing that bad.
That's pretty open. Yeah.
It's open with disease. Now, start focusing on that left side. You start seeing luminal loss of the external iliac in the mid portion.
Yeah.
And then it becomes a little thicker. It seems like it's a lot of just homogeneous crap.
That's out.
And then you see no contrast. So if you compare the right external iliac to the left external iliac here, you can tell that, that left external iliac is out. And I also see a clip, right? There's a surgical clip here, a surgical clip here. So I'm guessing, this is one where you pull the ligament and you may go all the way up and try to create that patch from up there, maybe. Yeah. And so let's keep going. Like, there's no evidence of reconstitution. There's no common femoral. Now we're clearly in the common femoral territory. As I said before, mind you, he had a common femoral endarterectomy with patch plus a common femoral 2 popliteal bypass remotely.
Do you know when?
2019 is what I want to say. So 4 years ago, 3 years ago. No, 5 years ago.
Yeah.
It's when he had his TMA.
Yeah.
So then he has this little island that comes back of what seems to be, in my opinion, a mini common femoral distal island that then goes away. It essentially goes. There's a mind. Let me just kind of like mag it up a little bit, but there is a little bit of that common. Then it seems like there's a thread of what seems to be the profunda.
And SFA.
The SFA is, it's like there's a little, 1 centimeter of SFA. So if you go, that 1 centimeter of SFA connects into a thready, very thready, but present profunda.
Yeah.
And then it disappears into that common femoral occlusion. And then the SFA occludes immediately. And what you see is really just a very small profunda.
Yeah.
Relatively small. Like I can't really even, I don't know. I'm also thinking this profunda, if you look at the profunda on the right hand side, look at that massive thing.
Yeah. But that's because it's filled, that's not a small profunda for being occluded.
I think there may be an occlusion of the second or third portion, but I may be wrong. I can't see it, here where it takes this quick lateral.
Yeah.
I would expect that this one that I'm marking, that should be a little bit more bigger, but then nothing. I'm glad
the cardiologist has such confidence in you.
But wait a minute. Let me tell you something. Here, this is faced in a better place. Because this one, they hold it off and it actually comes back in a better place. All right. And actually, what I'm seeing is it wasn't grafts, it was vein bypasses. Because I don't see either of them. Yeah.
Yeah.
Okay, so that I think that's a
bypass.
Yeah. No, I think that's a popliteal right here.
Yeah, but go proximal. Is that bypass? No.
These are the you can see the
you're going distal.
yeah. So you can see it was a below the knee popliteal to both sides. You can see the staples on each side,
yeah.
and you could see the
That's
skin
AP.
incision right here, right?
Yeah.
So it was a BK pop with vein, and I'm going back all the way up. And so you have an island that goes out, and then the external is out. On the other side, we'll go real quick over this because the other side has a non-healing wound, and I'm going to have to deal with that crap at some point.
Mm-hmm.
But I may have a little more time there. Totally an OBL case.
I mean,
the right
maybe.
side. I mean, the right side may even be worse. But the thing with the right side, the thing with the right side is that the common.
That's it.
The reason why the patient I think is better on the right side is the common femoral is actually open.
Yeah.
And it goes into the profunda that's open. So it's just that profunda is keeping it. So give me your thoughts here with what we got going on.
I mean, I think you tell your cardiologist to open that LAD first thing.
Really? You wouldn't try something potentially endo?
I mean, I can start thinking of like MacGyvering my way into it. I mean, I would come up and over, take a shot,
mm-hmm.
and then this seems like you probably can get P3 access. And then so I would come from below first and see what I get. And then I would target that island, and I would target the SFA first. So connecting that island to the SFA somehow, some way.
So wait, you would go up and over,
and
then try to cross the external iliac occlusion and the proximal common femoral occlusion. No,
I mean maybe that's an option. Like I was thinking of B-back, maybe like maneuvering the B-back into that island, and then going into the SFA and going down. That's an option, right?
Yeah.
Or
but wait, from where?
What do you mean? From up and over.
From the up and over, you would engage the CTO with a B-back, like almost straight up.
Yeah.
And try to kind of get that needle, do half throws.
Yeah.
To where it's essentially just angling and, kind of eating a bit at a time.
Or you can do like bidirectional right there. You can stick that proximal SFA and then rendezvous and then get into the SFA and go down and probably have to stick the P3 and rendezvous. And then knowing you probably Rotarex that. I would consider Rotarex, laser, combination of laser and Hawk probably. And once, you're probably going to need to stent the whole thing. You're probably going to need to stent into the common. And then I would probably Hawk, if it's safe, the ostium of the profunda. That's what I'm thinking. But then, can this guy like do mod sed?
Can he do what?
Moderate sedation. Are you gonna intubate him or no?
I think we could probably put him under general, just with like an LMA, right? Like a deep sedation.
No,
I think he could get a deep sedation. I mean, as long as you're not going to put him through some major cardiovascular, clamping and declamping of the aorta and stuff like that, I think he would be fine.
I would tank him up beforehand too. Hemoglobin at 10 for sure.
Yeah. Well, I have a fairly. I already have a plan A, and my plan A is not that. My plan A is going to be go up and over. I'm gonna park an 8 French sheath if I can.
Mm-hmm.
Then at that point, I'm going to come retrograde and poke into the little open stump of the SFA. That's all ultrasound guided. Shouldn't be that impossible, although it's going to be maybe fibrotic, and I'll have to deal with that. But then, I'll engage that CTO backwards, and I'll try to push a V18 into that common femoral occlusion. And then I'll try to put a little microcatheter, so I won't put a sheath at all if I can. And then I'll try to come from the up and over down, engaging the CTO of the external iliac from the top, and I engage the CTO of the common femoral from the bottom, and I'll try to find myself in the common femoral / external iliac occlusion.
Yeah. Why would you access the common femoral, not the proximal SFA?
No, the little SFA stump. Okay, little SFA stump. Yeah. If I am able to get that wire crossing, I would IVUS and get a better understanding of where I'm going to be. And then I'm going to, yes, to your point, I think that's all going to be clot and intimal scarring. So I'll probably run, depending on the size of the vessel, but most likely it looks big enough. So I'm probably going to bring an 8 French Rotarex. Oof. And I'm just going to eat that whole thing up as much as I can. I'm going to very aggressively debulk that EIA and that at common femoral. And if I am successful enough up to that point, that's where you and I would potentially divert, because what I would do is I would get an 014 command wire at that point into the profunda from the up and over. I would lose my retrograde wire, and then I would pre-dilate that entire profunda, common femoral, external iliac. And then I'm probably going to just drop a supera from the ostium of the profunda all the way, like a 7.5, all the way into the external iliac artery.
You're going to jail it?
Jail what? Jail what? The occlusion?
I mean, you can recannulate that SFA.
What for? To have a massive patency rate of 6 months or whatever?
Yeah.
What I think this guy with a profunda is going to be okay. He's demonstrated that he's fine on the right side with just a profunda. I think the fact that the profundas
that you're going to treat
on the right side, it's a little tiny wound. I may just leave it alone, man. I don't want to treat this guy with a 10-foot pole, period. But I mean, I got to get him out of the hospital, and I got to give him some degree of a life. As if I can just open the profunda, I would assure you that he's going to potentially be okay. I mean, I've shown you this. You know how much I trust in direct revascularization.
No,
remember
I agree.
Remember that one crazy case I also shared on the chat? We should probably go back and look at it. But it was this gentleman who had also a very complex external iliac and common femoral pathology, had an occlusion of that, and had a jump graft ×2, and it was this horrible thing, and nothing had really worked. But he had a really nice profunda, and on the CT scan, you can notice that there was a large collateral coming from the hypo, but the hypo was occluded. And then eventually, all I did is I recanalized the hypogastric artery, and I put a stent, essentially from the common femoral into the hypogastric. And it was through that hypogastric that the profunda would fill. And then from the profunda, the below the knee pop, and that guy's walking all over the place. And if you stick to the anatomic book answers to some of these cases, they're crazy. You're gonna like split the guy in half and try to do a bypass from the common iliac all the way to the popliteal. Well, that shit doesn't work. It doesn't last long.
I agree, but why would you? Like, that ostium is open by itself. Why would just touch it with the DCB and get out of there? If that's your plan, I would be hesitant to drop a stent in there.
I guess that's fine. I could not. It just looks like a disease.
It's
Let me go back at it. Let me go back to it. Let's look at it again. Let's look at it again. Let's look at it in a few different projections.
All right.
Okay, here we're coming. It's
not that bad.
Look at that poo-poo caca.
Look, yeah, okay. Touch it with the DCB, or hawk it.
Who uses the hawk? Are you looking at the profunda? It's got like 2 centimeters. Where do you want me to put that stupid nose? It's not going to go in.
Well, get this really small one, and then see.
All right, let me look at. Let's look at this sagittal view, because I think it'll be.
Or laser.
Help. Laser.
Bring out the laser.
Look at this. Okay. Oops. Okay. Oh. It's one of my biggest pet peeves that some of these softwares don't allow you to look to like you can mag up, but then you can't pan the image up.
Yeah.
Okay, look at this. That's the SFA. That's the SFA. And then this is the profunda I have to work with.
Yeah.
Like, see, I think when I see it in this projection, you see this little kind of.
Mm-hmm. Yeah, that was something.
You know what I think this is? This is heresy. I think whoever did that endarterectomy actually clipped the damn main branch of the profunda. That's a clip. Because you see the venous system here, and there is no artery.
I'm going to give that person the benefit of the doubt and just say that's calcium. Dude, I'm going to be kind to my colleagues.
It's a flipping clip. I can't believe they
I mean, the profunda is not that. Like, I just can't. It can't really. You're flipping around back and forth. Like, I can't really look at the ostium.
Of what? Oh, you can't see the ostium of the profunda because it comes right at you.
Oh,
it's here. It's that little dot.
That little dot. It's not
so bad. Let me see. Corona will probably be better. Let me see. Oh God, it's so small. If I had a penny for every time I've been told that.
What about someone says, bro, just open up that LAD and they do a coming from an endart with a patch.
That's what that's what Bernardino's gonna say.
I know. Can you do a Bernardino impression?
Miguel, stop scratching your head over this. This is open. 100% of the time. Open it. Don't screw around with this. Get it open. Don't let the guy bleed. Send him home the next morning. What are you thinking?
And you know what? Bernardino's smarter than both of us combined.
He is so smart, right. Even though he doesn't let us air any of our shows.
I know.
Maybe we can bring him to a case cast. He's always got really smart things to say.
I know. Actually, that would be a great idea.
Miguel, what are you doing? You are just around with this. Don't just open the damn thing, clean it up, be done, go home. Go home.
Stay with your kid.
Make sure you don't let the cardiologist ever close to this guy again. I don't know, man. Look at that little tiny little effer.
Yeah. What would Jerry say?
I just think you should disarticulate this dude. That's what Jerry would say.
He would.
Listen, this guy do fine. The best you can do for him is get him a wheelchair. And that'd be the end of Jerry's comment.
Yeah.
Are you still going to give him the benefit of the doubt on those little white things in the back
I'm
being
ignoring
calcium?
I am.
I don't know, man. It'll be interesting. So I'm gonna go with. Yeah, I'll give it a shot. Endo, with my intention to just focus on this. I mean, it's. I'm not gonna jinx myself, but we're looking at a 6 centimeter CTO. If I could get that profunda back in line, I don't think I'll be. Here's the deal, though. Would we agree on this? If it works out, fine. Live to tell the story another day. If it doesn't, push cardiology to fix his heart and then do it open? Or would you do it open tomorrow? Like, would you convert? And just...
I mean, I would sit down with the patient. I would take 30 minutes of my day to sit down with this guy.
Yeah.
And just say, hey, man, what do you want me to do? Because
I also think it's
a rock and a hard place.
Yeah, and I think it's a little callous to see a redo. So it'd be a third.
This is a
yeah.
Oh, okay. So the redo. Okay.
Yeah. So it's a second. So the first one was the ENDART, and then they went in and then the bypass off the patch.
You're sure they didn't do it at the same time?
Mm-hmm.
Oh.
Yeah. And so anyway, all to say, not that I wouldn't, but you need to believe that there's going to probably some bleeding. That you're probably going to want a self-saver.
Yeah.
Right? I mean, it's a case that you're going to want some good hands helping you, all these elements that you need to have. And I think to your point, I would probably push the cardiologist, say, listen, there's no way that I can safely do this if you have these significantly reversible lesions on our PET scan that you have already proven to us that there is a lesion that could be treated.
Yeah.
Regardless of what that treatment is. And
I would talk to him about an AK even after you revascularize him. It's just that stent, it's not going to last long, right? Coming from an ENDART lasted 4 years.
Just about.
That stent's going to last less.
Well, and mind you, remember this guy's still smoking, right?
Yeah, that's what I'm saying.
Like some of our colleagues would not even touch this guy.
Yeah.
What's your thought on not operating on patients that are actively smoking?
I don't operate on them if they're for claudication at all, if they're smoking.
Right.
And then for limb salvage, I operate on them. I mean, I'm not gonna let someone suffer away in a bed with pain just because and it's a vicious cycle, right? They have pain and they need to soothe themselves with a cigarette. So that's not fair. It's not a moral shortcoming or anything like that. It's a tough spot,
Yeah.
So,
well, what else? I mean, you could do. Let's talk about stuff that we have seen and we probably wouldn't do. Fem to below the knee pop crossover. I've seen that crazy shit.
Wait, what?
Like instead of a fem, a fem pop.
Oh yeah, I would not do that.
I've seen an axe pop.
I would not do that.
Yeah, I know. I'm saying things but I've seen one.
Yeah.
You've never seen an axe pop?
You know what I saw and dealt with recently?
I'll take your axe pop and I'll raise you a
bilateral axe by fems for claudication.
Oof. Yeah.
And then comes infected, obviously.
Ugh.
Yep.
Yeah. Yeah, the stories of infected ex-fem are very interesting. But yeah, I just don't see anything right now that I think you either do an insight to I guess you
I like
could.
vein mapping too. I mean, I think that. I mean,
I mean,
if you have,
you could do an RP incision. I guess you could do a fem profunda.
you can do a fem profunda. Well, you can do a
But
iliac.
this looks like
You can do an
that's
iliac.
the other thing. You could. I mean, you could do an RP exposure in a very small incision and bring out the common, right? Because the external is out, but maybe you could get to the common, go just a little bit higher up, and then you do a common iliac to the profunda, or you could do a common iliac to the popliteal.
Well, you can do an external iliac to
It's
profunda
occluded
with
though, right?
lateral exposure.
Well, I guess you could do a lateral exposure of the external and clear it out.
Yeah, you lift the sartorius, you go underneath, you find the profunda, and then you do RP incision, and then tunnel.
You can definitely do that.
That's a. I mean, if the guy has a honking basilic vein or cephalic vein, you know.
I want to say now that I've seen this, but I would be lying. I'll have to come back to you. But I want to say that he doesn't have vein because he had vein used for both of his bypasses. Although I wouldn't be surprised if somebody did cadaveric bypasses on both sides.
Yeah, but he might have something in his arm.
Yeah.
Yeah.
Where you can fish out some femoral vein, but that just limits your distances.
Yeah.
Anyway, I still think I'm going to give it a good shot with endo tomorrow. Yeah. I will not escalate. If I am unsuccessful, I will stop there and I will not escalate to anything else. I would probably go back to the drawing board, talk to cardiology, and come up with a better plan.
I mean, I think you will get through. I mean, I think that will be, not.
Don't jinx me. Don't jinx me. Don't jinx me. Don't jinx me. Well, dude, I never go pot. I am always glasses half empty.
That cardiologist thinks you're Jesus Christ reincarnated.
I always go thinking I'm not going to succeed, and it's usually what works. And when I get cocky, I get just kicked in the ass. So I'm very, very, very unsure that tomorrow is going to work out, but that's the plan. And if you guys stick around and continue listening to the best podcast of the world, you will listen to the end of this because it's not going to be, we're not going to air the end. Or maybe, yeah. I mean, if I do it tomorrow, maybe I can be able to add a couple of sentences to the end.
Yeah. We'll see.
We will see, but maybe not, you will know what happened.
Keep the suspense.
Dun, dun, dun.
Yeah.
All right, man. Well, thanks as always.
This was good.
It's always great. It's always great to talk to you. It's always great to get your perspectives and to have somebody else to talk and bounce ideas. I always appreciate you for that. So hopefully everybody out there will appreciate it too. All right?
All right, man.
All right. We'll close it for today.
A few moments later.
All right, Lucas. Well, here we are. A few hours have passed since we first talked about this. And certainly a few hours in the operating room have passed. I want to say this took about 4 hours to do.
Damn.
Give me a second. Let me see. I started 3 hours, about 3 hours.
Okay.
Yeah, certainly more than I expected it would. Probably because you said it'd be easy. So you jinxing at the beginning.
I love jinxing you.
But anyway, so, up and over from the right side. And what you see here is this occluded common femoral. We had already identified that on the CT very well. And here you see also on the right, the little piece of patch. Remember that the patch kind of came back up and it seemed like there was a stenotic region of the profunda.
Yeah.
And there was a little tiny bit of SFA. And so this is what the angiogram looks like. I did not get that retrograde access from the front end. I tried to wire from the top just to see, I wanted to know if the wire just slides, then obviously it could be more acute material. If the wire doesn't slide, then obviously I'm treating some chronic stuff here. So muckered around with that for a while, and finally was able to realize that I wasn't going to get anywhere from the top, so I got access from the bottom. And so this is a 5 French sheets from the bottom into the batch. And then it took me a long time to just get past that little cap from the bottom up. Like it was glued in. Like at some point I thought I was going to have to give up.
What you use to kind of
Well, what you're seeing
push
here,
through?
that's a V18 literally curled up into multiple circles. That helped me get the 5 French precision in, and then I use an 035-65 Navi as support for the 5, and still I couldn't get anything. Ultimately, what did the trick was a 018, a Victory 18, so a CTO wire, and I did a telescopic technique. So I put the 035 Navi, and I put an 018 microcatheter into the Navi, and then to those two, I pushed with an 018 CTO wire, aka Victory 18. With that, I was able to just advance about, call it 2-3 centimeters into the CTO, but I was very far away from the antegrade dissection. So I did the same thing from the top.
How come it seems like it's a short distance? What are you?
Yeah. So you see that the full CTO is about 5 centimeters. And so I advanced a couple of centimeters from the bottom. I was able to advance almost all the way down from the top, but the problem is the top would just go on the side of the vessel. It wouldn't like pop back in.
Yeah.
So ultimately I did a few different things. So I did reverse cart, and then dual, and all that failed because I just couldn't get these two wires to connect.
Yeah.
So I ended up pulling an outback catheter, and came from the top. I was able to navigate it in, and still, despite my best attempts, from the top, the outback would just not poke in. Like that material from the surgical side is glue in there, and it's so
cement.
A lot of times, the only thing that helps is if you put a blind laser catheter and you kind of make some burns, and that's what'll get you through. But in this particular case, it just didn't. So let me walk you through to the second slide. That one, and what it shows is a gun sight or slingshot technique, where what I ended up doing is I went into that CTO space and I put a 4mm gooseneck from the up and over, and on the bottom I put a little trilobe snare. I was able to get one of the lobes of the trilobe and the 4 aligned. So when that happens, from the outside by X-ray, you can essentially poke a needle right at the groin and go through and through these two.
And that's at the point of the vessel that's completely occluded, right?
Yeah,
it wasn't at the island.
I did it right in if you look at the bony structures, I'm below the inguinal ligament.
But not yet at the island of...
I made sure that I did the connection in the CTO because I didn't want to put any of these collaterals at risk. There were so many collaterals coming off of that island that I wanted to make sure that the crossing, the ballooning would eventually not compromise anything.
Yeah.
So I then pulled, so once the wire, like the needle was through and through, and then you put an 014 wire, I pulled the snare from the antegrade up and over axis and recovered it. And then I pulled whatever, half of the 014 wire. And then I pulled the one from the bottom, and at that point I had it through and through. So once I had it through and through, obviously you kind of macerate the wire by doing this technique. So I put a microcatheter. I used the same 018 Navicross to go through this wire that was all kind of buggered up, and I changed that for the 018. You're gonna love this, the Rotarex wire.
Surprise, surprise.
Surprise, sorpresa. I then did IVUS, and quite frankly, I was very happy that I did IVUS, and I should have gotten you a couple of images, but you could see there was some like clot in the EIA, sorry, in the external iliac. And then it was just this fibrotic tissue in the CTO and through the crossing. So what I did is I rotarex that, was able to clear the clot from the lumen of the external iliac, and then was able to cross with the rotarex through all the crappy area. And it actually yielded significantly well. And then I ended up, okay, here's actually a nice image. This is with a roadmap of that kind of little path that we had, and then the rotarex doing its thing through that. And then what I did after that was I used an 8mm balloon to essentially balloon from the bottom of the staples all the way up to the top of those staples, which was all patch at some point. And then I ended up dropping a 6.5 by 80 rotarex. So, I'm sorry, a Supera.
Supera.
So after I pre-dilated with an 8, I dropped to 6.
Why not bigger?
I didn't have that. That was the size I had available. I reached the company. I wanted to get a 7.5, but after I dropped it, I mean, it looks actually pretty good. You see the proximal edge. Maybe there's a little bit of a mismatch, but it's very slight. And once it goes, once it goes into the CTO, it was fine.
Yeah.
At the end, what you can see is that island of SFA is open. The profunda is a piece of crapola that we had already. Remember that I told you that the second portion seemed to be occluded.
Yeah.
But if you follow this significant amount of collaterals, which, by the way, if you've never seen a burger, welcome. This is exactly what they look like. So this is
burger's disease. I like a burger.
Yeah, burgers.
A cheeseburger.
Verguero. Because remember this guy's this active smoker we talked about?
Yeah.
I think that this guy is just screwing himself, and he probably has a vertigo that nobody's really mentioned or cared for. And, normally is a little bit more distal, but it's not uncommon to find more proximal disease. And what you see here is this, capella de medusa, in other words, where this profunda just has all this, and it reconstitutes that below the knee pop as we saw it in the CTA. And then the one vessel that's nice all the way down to the foot is that antivial, as you could see it there.
Yeah.
Anyway, I had no signals to begin with. I had a foot signal thereafter, monophasic. So I expect that to probably increase. I keep him on a heparin drip. He's on full dose of antiplatelet therapy. And I'll check on him. But anesthesia was obviously very happy. They were very nervous. Cardiologist also was a little nervous. He said, please call me after the case. Tell me how it goes.
Yeah.
But anyway, the best case scenario here would be that his rest pain gets better and that we just stop at this. I would advocate to not push our limits a whole lot more.
Yeah.
So we'll see.
I would agree.
What do you think?
And then you have the other leg to go, so good for you.
It's like a very superficial wound. I'm
really, you gotta hyperbaric that.
I'm really gonna try to just do optimal wound care and see what we could do. I think his PAT is like class 3.
Yeah,
should be okay for something that superficial, and we'll see how he does. But anyway, I thought it was cool to kind of
wrap up the
pod so that everybody gets the A to Z of how we work, and then you take sometimes wins and you take sometimes losses. But thankfully today we were resourceful enough to have a few tricks that got us through. If I wouldn't have done that slingshot in this story, there's no way I could have done that case.
Maybe B-back, huh?
I don't know. Maybe a double B-back of some sort from the top and the bottom. But it's that material. It's kind of almost like silicone, right? Like it's this rubbery thing, and it's so hard. A wire doesn't go. It's not like plaque. the needle doesn't project appropriately. Again, VBAC does have some additional advantages in regards to the mechanics of the needle, but who knows? We'll have to we'll have to pressure test it.
Yeah. Well, great case, good save, and you live to fight another day. So
yeah, I'd love to. I'll add what I think would be nice as a cherry here is let's get them some hemodynamics. So when he comes to the clinic, see what his PAT is and see what's going on and see how he's feeling. So I'll keep you all posted, but I hope you enjoyed our conversation here. We'll see you on the next one.
All right. That was great. Thank you.
All right.
Vamos.
Vámonos.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.